Every practice owner knows this scene. Your front desk team is managing check-ins, handling walk-ins, and tracking down providers, all while the phones continuously ring. The staff is doing their best, but they are structurally overloaded. When the daily rush hits between 8 and 10 in the morning, and again right after lunch, the volume of simultaneous demands exceeds human capacity. This funnel represents 100 incoming calls. For the average medical practice, 34 of those calls drop out before reaching the bottom. They go completely unanswered. A single missed call represents the start of a structural revenue leak for the practice. The standard assumption is that a patient will hang up and dial again. However, data shows 85% of patients abandon the attempt entirely after their first unanswered call. Miss just 5 appointment calls a day, and those dots accumulate. Over 1 year, that stacks into $144,000 in lost revenue. Worse, 41% of those frustrated callers switch to a competitor. This loss includes both the immediate appointment revenue and the entire lifetime value of a patient relationship that never had a chance to start. Treating phone administration as a secondary task effectively subsidizes your competitor's growth. The immediate instinct is to hire another receptionist, but adding another desk phone does not address the root cause, an industry-wide staffing crisis. Single specialty practices see a 40% annual turnover rate for front office staff. Each departure takes between $9,000 and $12,000 in recruiting costs. This scheduling spiral forces remaining staff to absorb double the call volume, leading to burnout and missed calls. Then there is the after-hours blind spot. 11% of patient calls happen outside standard business hours. These are high-intent callers currently reaching an unanswered voicemail. You cannot out-recruit a 40% turnover rate. Stopping the revenue leak requires a change in the workflow system. One approach involves separating routine administrative calls from clinical care using remote healthcare virtual medical assistants, or VMAs. These are trained specialists who log in securely and operate directly inside your existing electronic health record system. They work on your local time zone. Real-time AI voice neutralization runs in the background, ensuring every interaction sounds professional and natural. This AI priority engine intercepts overflow data, instantly ranking it by urgency, complexity, and deadline. It also uses capacity planning algorithms, analyzing historical call trends to predict peak times and dynamically adjust support. By pairing human empathy with automated sorting, the practice creates an administrative safety net that scales with patient demand. Factoring in base salary, payroll taxes, benefits, equipment, and turnover, an in-house seat costs nearly $60,800 annually. The virtual medical assistant model costs $21,600 for exact same coverage. That's a 64% reduction. The model is elastic, allowing practices to scale down. If you only need coverage for high-volume windows like Monday mornings, you can shift to pure hourly support. Data remains protected within HIPAA-certified environments, using encrypted VPN connections and constant audit logs to ensure compliance. This outsourcing model protects the patient experience while freeing up nearly $40,000 per seat. Implementation happens fast. A fully operational EHR-integrated team can go live in 48 to 72 hours. With the phones managed offsite, the physical environment of the clinic changes. Your in-house staff finally have the time to provide warm, attentive care to the people standing right in front of them. There are no long-term contracts. A 30-day satisfaction guarantee allows you to test the system risk-free. Call overflow is a solvable data problem. Smart practices are plugging the leak, reclaiming their revenue, and restoring their peace of mind.